so I'll be your student nurse today. Today we'll be putting an NG tube in. So what you could use this for, it could be for enteral feeding, which once you've confirmed placement of the NG tube, you would hook it up, depending on the order. You could hook it up to a pump, do it by gravity, or a bolus with a syringe. And then you can also use an NG tube for decompression if that is what the order is for. So depending on the patient needs, that's what you do. I'll say my doctor order is for decompression today. So I want to explain the NG tube is uncomfortable to have put in. So how I can have you help me out is I'll talk you through it. And as I'm progressing down the throat, I will have you drink, and keep swallowing as fast as you can. You may get the urge to throw your head back. Most people do. It's a really natural response. So I'll just keep reminding you to keep your chin to your chest and keep drinking that water. But first I'm going to have your head tilted back and I'll tell you when to tilt it forward. So we just want to make sure that I do a really good skin assessment on you here. So I'm going to look in the nares. I want to look for any abrasions or bleeding. And ask the patient, have you ever had any facial trauma, been in a car accident that caused trauma to any of your facial area? Any history of deviated septum, or do you currently have one, or have you had surgery on one? And then, if it's all right with you, I'm just going to plug one of your nares and have you take a breath through your nose. And I'm going to do it on the opposite side. Okay, did you have difficulty in either of those? No, okay. Now I'm going to measure, so let me get a piece of tape. I'm going to measure from the nose to the earlobe to the xiphoid process. And while I'm doing this and getting my stuff ready, I want to explain to them that this is uncomfortable, but we do have measures we can take to help their discomfort. So we do have spray that we can help. Your throat will probably get pretty sore. We have lozenges that can kind of numb that, and then we will be doing very close daily care. So I'll be changing this bandage every day because we want to be careful of any discomfort on your nose or any kind of new abrasions or anything. Okay, so I'm gonna measure. So I want to go from the nose to the earlobe. Right about 18. So I'm gonna put my gloves on just because I'm gonna open the tube. Not that this is a sterile technique, but you do want to be clean. You don't want to be gross about it. Like I said, 18. I'll open up the top here and the tube. And I'm going to measure to 18, so we're right here. And you want to put tape on it because sometimes in the heat of the moment, you forget where you're supposed to push it through. And we definitely want to get it in the right place here. So I am pushing until about 47. So then I want to lubricate this. So normally if on a human, you would have a little lubricating jelly and I would just stick it in there and leave it in there until I'm ready. For this, I have soap and water. So that will be what we'll do here. Okay, and then I want to get my stethoscope ready. And then I have my emesis basin to check the pH once we're in there. So first, I want to make sure I have my pet light. All right, sir, so I'm going to have you first tip your head back for me. Then when I tell you to tip your head forward, you're gonna keep drinking this water and try to swallow as best you can, okay? So for demonstration purposes, I'm gonna be pushing the patient's head. All right, ready? All right, now tip forward and drink, 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 drink. Okay, so let's say I hit resistance. I wanna make sure and take a look in the back to make sure that I'm not coiling up in the back of the throat, because that can happen. And then also if the patient is kind of excessively gagging, I would maybe want to give them a minute, have them take a couple drinks of water, and a few breaths to kind of gather themselves. If I was really stuck and couldn't get through any further, I would take it out and re-lubricate it and start again. And I can do that because we're just going into the stomach, it's not sterile. So I'm gonna keep pushing. We're gonna go. Oh, maybe we're not. Let's re-lubricate it. Okay, all right, let's do this again. I'll have you tilt your head back. Good, all right, now tilt forward and drink, drink, drink. Good, all right. We're right to the tape. Because I'm doing this by myself, I'm gonna secure this right away. And if the patient were like excessively oily or anything, I would have used an alcohol pad or some skin prep on their nose, just because you really want this to stay. You don't want to have to do this again because this stinks. So I'm going to secure it there. And I am going to aspirate some content. Oh, I got stuck back. Oh. I got some stuff coming, so I'm going to plug it up here like this. I'm going to put my pH strip in there. And this is to test, you want to make sure the contents you're getting are from the stomach. So I'm putting my pH strip in there. The stomach should usually be 1.5 to 4. But it's not necessarily used because it's not the most accurate tell of proper location. So the most accurate is X-ray. But right now, while I'm doing this, I'm testing the pH, and then I'm gonna aspirate air into my syringe. Let's get all that out. Okay. Air into my syringe, and I'm gonna put my stethoscope over the stomach and listen for a swoosh. All right, I got a swoosh. I also forgot to say in the beginning, I know he has it on already, that I would definitely put a Chucks on because you don't want it to get messy, but it can. So then I want to secure this tube further down, and you don't want to make it too tight because you do not want that thing getting pulled out. So then what I'll do, I said I'm doing this for compression, so I'll connect it to the suction. And I still have my connector here, so I'll connect that right away. And then this little blue pigtail is it's used to keep air, so it's not like a vacuum in the stomach, so that it keeps that lumen off the stomach lining, because if that gets stuck on there, you can cause a lot of problems. You can cause bleeding, anything like that. So then what I want to do now is document my findings. I want to document the color, odor, any defining characteristics, and the amount of aspirate that I got back. I want to document how the patient tolerated this. I want to document what it's being used for. where it was placed, so the number that it was at, because that tells other nurses if it's still in place or not. And then again, the best tell is an x-ray. So could we start doing things before the x-ray? Depending on what it is, yeah, but you wanna make sure that you get that x-ray back and that it tells you that it's the correct placement, because sometimes you'll get the x-ray back and they'll just say, advance it 2 to 4 more inches.